Trauma-informed care. You know the old saying, don't judge a book by its cover? Well, the same is true when you assess a patient. Some patients are uneasy about being in a nursing facility. They often have multiple health issues, are uneasy during exams, visitation, doctor visits, and frequently visit the emergency department. But worst of all, they never get better despite multiple visits to the doctor. Something from their past. The patients were exposed to some sort of trauma. This includes natural and human-caused disasters, accidents, war, physical, sexual, mental, and/or emotional abuse, either past or present, rape, violent crime, history of imprisonment, history of homelessness, traumatic life events, such as death of a loved one, personal illness, etc. For some people, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So, as days and years go by, many struggle with issues related to emotional regulation like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. You can begin to rethink your approach to care. Instead of asking patients, "What's wrong with you?" you can ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped us take these experiences into account, providing greater insight into the patient's needs and how to address them. Trauma-informed care is an approach to delivering care that involves understanding, recognizing, and responding to the effects of all types of trauma. A trauma-informed approach to care delivery recognizes the widespread impact and signs and symptoms of trauma in patients, and incorporates knowledge about trauma into care plans, policies, procedures and practices to avoid re-traumatization. Culture is the conceptual system that structures the way people view the world. It is the particular set of beliefs, norms, and values that influence ideas about the nature of relationships, the way people live their lives, and the way people organize their world. Cultural competency is a development process in which individuals or institutions achieve increasing levels of awareness, knowledge, and skills along a cultural competence continuum. Cultural competence involves valuing diversity, conducting self-assessments, avoiding stereotypes, managing the dynamic of differences, acquiring and institutionalizing cultural knowledge, and adapting to diversity and cultural contexts. In communities, here are some key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Educate staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or admission staff, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider a screening approach that works for your patients and ensure that treatments and referral sources are available. Compliance guidelines. 1. The facility will work to facilitate the principles of trauma-informed care, which include A. Safety, ensuring residents have a sense of emotional and physical safety. B. Trustworthiness and transparency, efforts to establish a relationship based on trust, and clear and open communication between the staff and the resident. C. Peer support and mutual self-help, if practicable, assist the resident in locating and arranging to attend support groups, potentially hosted by the facility, which are organized by qualified professionals. D. Collaboration, an emphasis on partnering between residents and/or his or her representative, and all staff and disciplines involved in the resident's care in developing the plan of care. E. Empowerment, voice and choice, ensuring that residents' choice and preferences are honored and that residents are empowered to be active participants in their care and decision-making, including recognition of, and building on residents' strengths. 2. The facility will use a multi-pronged approach to identifying a resident's history of trauma, as well as his or her cultural preferences. This will include asking the resident about triggers that may be stressors or may prompt recall of a previous traumatic event, as well as screening and assessment tools such as the Resident Assessment Instrument, RAI, Admission Assessment, the History and Physical, the Social History/Assessment, and others. 3. If the resident is non-English speaking, the facility will identify how communication will occur with the resident. If indicated, language assistance services will be arranged for the resident. The care plan will identify the language spoken and tools used to communicate. 4. The facility will collaborate with resident trauma survivors, and as appropriate, the resident's family, friends, the primary care physician, and any other healthcare professionals, such as psychologists and mental health professionals, to develop and implement individualized care plan interventions. 5. In some cases, if the facility has more than one trauma survivor, social services will make a good faith effort at coordinating and referring the resident/residents to a support group that is run by a qualified professional or allow a support group to meet in the facility. If a group cannot be run/meet at facility, social services will assist the resident in locating a support group in the community as appropriate and feasible. 6. The facility will identify triggers which may re-traumatize residents with a history of trauma. Trigger-specific interventions will identify ways to decrease the resident's exposure to triggers which re-traumatize the resident, as well as identify ways to mitigate or decrease the effect of the trigger on the resident, and will be added to the resident's care plan. While most triggers are highly individualized, some common triggers may include, but are not limited to: A. Experiencing a lack of privacy or confinement in a crowded or small space. B. Exposure to loud noises, or bright/flashing lights. C. Certain sights, such as objects that are associated with their abuser. D. Sounds, smells, and physical touch. 7. Trauma-specific care plan interventions will recognize the interrelation between trauma and symptoms of trauma such as substance abuse, eating disorders, depression, and anxiety. These interventions will also recognize the survivor's need to be respected, informed, connected, and hopeful regarding their own recovery. 8. The facility will evaluate whether the interventions have been able to mitigate, or reduce, the impact of identified triggers on the resident that may cause re-traumatization. The resident and/or his or her family or representative will be included in this evaluation to ensure clear and open discussion and better understand if interventions must be modified. 9. The facility will engage the services of an interpreter to monitor or evaluate the effect of cultural interventions for non-English speaking residents. 10. In situations where a trauma survivor is reluctant to share their history, the facility will still try to identify triggers which may re-traumatize the resident, and develop care plan interventions which minimize or eliminate the effect of the trigger on the resident. These changes take time, but each step improves our ability to connect with and care for patients.